All right, welcome everybody. It's my privilege to introduce to you the session of When Suicide Seems to Be the Answer, Psychological and Spiritual Implications for Care. And these two gentlemen I've had the joy to meet over the last few years. So we have psychoanalysis and psychiatry, and I know that this doctor here has lots of good theological questions, and Stephen is working to integrate these two, so I look forward to hearing him. Which one of these? Neither are on, huh? All right, let's see. Now, good.
Thank you, and thank you for coming. My prayer today has been that the information that's conveyed here is somehow useful to each of you. I'd like to front load a couple of things, one being an apology for the amount of information. This is a big topic, and so I'm going to make an attempt at helping you regulate that, knowing that it's a lot of information, but you won't get it all. You can go back and listen to it later on Ancient Faith. You can request a copy of the talk from me if you like, or Dr. Mustada. And also, let's see, there's a third way in the publication. It'll be in the publication next year. So you don't have to get it all today. So, okay, I'm going to jump right in. Suicide does not represent what is considered to be madness in the matter that we consider mental illness. It may be associated with mental illness, but does not represent mental illness on its own. However, because of the extremity of the behavior, as well as misunderstandings about what suicide is and represents, I feel it's extremely important to address the state of mind and associated destructive behaviors. It is not uncommon to think that one must be crazy to attempt or complete a suicide. Based on the importance of helping those who are attempting to give up on life or who have attempted to take their lives, we must strive to understand more about suicide. The contemplation of suicide is a very focused state of mind, whereas in the psychotic state of mind, where the self is out of space and time, or in cases involving extreme dissociation, when uncomfortable experiences are pushed away completely, the suicidal person is very aware and hyper-focused on their dilemma. Typically, they are quite aware of their circumstances and their pain. Subsequently, they have narrowed their life down to only one issue, pain, with the solution being to relieve this pain. In fact, as we shall see, they are too focused on the imminent solution of suicide. Often the thought of suicide itself is enough to provide relief. Nietzsche once said, "The thought of suicide is a great consolation. By means of it, one gets through many a dark night," unquote. It is the phenomenology of pain and loneliness, along with the spiritual implications, that this presentation will seek to define, understand, and help orient our responses to suicide. There are other motives for suicide that extend beyond the scope of loneliness. However, for both brevity and the theme of this conference, I will not address these as I have elsewhere. The challenges of relating to the suicidal mind are not always straightforward. I will attempt to address this complexity. Suicide's relationship to suffering, or an individual's inability to come to terms with what feels like unbearable suffering, is a key part of this effort. Previously, I have described psychopathology as the inability to suffer. This is not a new idea, the value of suffering, but I've wanted to extend this notion to suicide with the perspectives of psychopathology and the resistance to suffering. With this perspective in mind, in the following, I intend to define and portray the idea of suicide as the idea of intolerable suffering as it relates to to suicide. Now some suicidal statistics. In the last 45 years, suicide rates have increased 60% worldwide, and it's the third leading cause of death among those aged 15 to 44. Suicide attempts are 20 times more frequent than completed suicides. Each year, approximately 1 million people die from suicide, which represents a global mortality rate of 16 per 100,000 people. This amounts to one death every 40 seconds, and it has been predicted by the World Health Organization that by the year 2020, the death rate by suicide will increase to 1 every 20 seconds. Sharp rises in suicide rates are found among minorities, homosexual, and other gender identity groups, the elderly, and the young. Okay, now some definitions of what suicide is and what suicide is not. Suicide is neither a mental disorder, simply explained by a psychodynamic formulation from childhood, nor a neurochemical imbalance, a personality trait, a psychotic condition, a sociological construct, a spiritual illness, or any of these by themselves. However, each and all of these factors may contribute what amounts to suicide ideation and or suicide attempts. Suicide is best seen as a multifactorial event, which has been defined by the suicidologist Edwin Schneidman as a conscious act of self-induced annihilation, best understood as a multidimensional malaise in a needful individual who defines an issue for which suicide is perceived as the best possible solution. Notice, perceived. Notably, in the context of this definition, suicide is not considered as the result of being out of one's mind, but rather a conscious choice, an act done with perceived clarity. On the other hand, the conscious decider may be limited by the severity of the present circumstances. An individual whose mind is focused on elevated pain and frustrated needs are not usually psychotic, but disturbed, indeed perturbed. Suicide involves a state of being in which the perturbation is elevated and involves a perceptual narrowing that becomes misperceived as the best possible solution, reminding the suicidal person that they have loved ones or an unknown future to explore may be acknowledged but pushed away as irrelevant. Their selectively narrowed attention is the focus on what they regard to be the only solution, suicide. On the other hand, acts of self-harm that are not in themselves lethal, such as cutting or burning of the skin, may not be suicidal. It can be very disturbing for loved ones, clergy, or clinicians to discover these behaviors. My discussion is not intended to give rise to the fears that these behaviors are expressions of suicidality, although the level of potential for suicidal activity should be routinely assessed in relation to self-harming activities. A significant proportion of these behaviors have a different aim. Frequently, non-lethal acts of self-harm are meant to release pain and other very uncomfortable pain and become an attempt to restore some feeling of aliveness. Nevertheless, while it is not appropriate to accept these behaviors as constructive solutions in lieu of other effective and adaptive means of addressing emotions, or the lack of them, as it may be, it is also important not to overinterpret them as necessarily suicidal preoccupations. Clearly, caution and understanding are warranted in these instances. Regarding the preoccupations of suicidal individuals, another myth is to dispel is the correlation between death themes and suicide intent. Many individuals appear to be morbidly preoccupied with dark themes of death. Suicidal individuals are preoccupied with their unbearable pain. Therefore, for suicidal individuals, the movement is away from unbearable circumstances and the pain it generates, rather than moving towards death. From their perspective, the problem appears to be not death, but what feels like a failure to making life be more livable. This is an important distinction because death becomes the fantasied solution to the problem of reality. For the suicidal person, their pathological construction dictates that they need a solution to their painful and pressing problem. Also, some of these individuals have the ability to suffer for long periods, while others have lower thresholds to endure suffering. Regardless, hope can be found in understanding that the suicidal state is usually transient. Upon further exploration, it may be found that they are in fact highly ambivalent to present circumstances and need help to be able to see this. Now let's look at suicide and its relationship to other disorders and life circumstances. While mental disorders are not direct causes, they are associated with more than 90% of all cases of suicide. This appears to mean that a variety of concerns, situations, and emotional disorders correlate with, but do not cause suicide. For example, according to Schneidman, theoretically no one has ever died of depression. This is not to say suicide never arises out of a severe depression, a psychotic break, or that the result of an overly impulsive person's reckless response to a stressor might not be a primary cause for suicide. However, a preponderance of the research indicates that suicide itself is almost always an overly focused, immediate solution to pain and frustrated needs. To discuss the issue of present pain, the immediate experience of the suicidal individual, I'd like to show or read you an account of a person who was in a state of mind and failed at their attempt to suicide. This example gives a very helpful insider's view into the state of mind and feeling, including the gratification regarding dying as a sole solution. And I quote, "And I remember then pouring the gasoline first over the front seat and, of course, over myself to a great extent. And even then, no thoughts went through my head at all of the pain that I was going to feel, the misery, the hurt, any of that. It just felt good. It was the first time, in fact, that I had felt at peace, that I wasn't hurting inside. And for once it seemed like I had taken care of my problems and that my pain would just go away. I was not going to exist anymore, especially in my mental pain." The literature is replete with examples of this state of mind and the fantasy of relief from present pain. I have also worked with individuals who have been passively suicidal for many years. They can derive a source of comfort from knowing that they have an exit planned if they needed to relieve some sort of serious underlying pain that has made it hard for them to be in this world. However, they have also remained in therapy hopeful that one day they could find a life more livable and sustainable in this world. An irony of this state of mind, wanting to die, is that final annihilation is an attempt at self-preservation. It seems that if this seems confusing, it is, because this perspective calls into question the validity of Freud's so-called death instinct. Can self-preservation be correlated with the desire to die? It is a skewed conclusion to consider ending a temporary problem with a permanent solution. This can help us develop further understanding and compassion when confronted with a suicidal individual. Moreover, this awareness can reinforce a sense of hope while working to enlarge the client or patient's view beyond their narrowed and negatively egocentric view of their condition. As mentioned, some individuals are highly ambivalent to the idea that they wish to die. I'd like to talk about this with the framework of loneliness. After a suicide attempt, some discover that they also had a powerful fantasy to be saved. As reported by the 20th century psychiatrist Carl Menninger, every hospital intern has labored in the emergency ward with the would-be suicides who would beg them someone to save their lives, which of course raises the question of whether they truly had wanted to die. Further, it is reasonable to ascertain whether the would-be suicide had a rescue fantasy or change of heart. Ultimately, for some, the rescue fantasy would also reflect a need to escape loneliness through being found and rescued by another. More than signals for help, failed suicide attempts often reveal important underlying symptomatology and deep personal needs. McGuire and Troisi propose that some suicide threats can be understood in the context of frantic efforts to avoid intolerable loneliness. As put forth by Freud, human beings to the end of their lives desire love, real care, as well as symbolic proof of being valued by others, and a sense of belonging. Distressed individuals, however, fear or shun relatedness and live isolated from others as well as from loving internal objects. Although a sense of self-sufficiency and creativity may provisionally protect oneself in such circumstances, these ways of experiencing oneself may also conceal profound loneliness. When psychic pain penetrates into early narcissistic scars, the depletion of the feeling that one is loved may lead to self-destructiveness and suicide, end quote. Similarly, Jane Milton writes that loneliness is the result of a hopeless longing, which in severe cases can lead to suicide. And Melvin Singer adds that agonizing loneliness without relief can bring on suicide attempts. Maltzberger and his associates write that true isolation or aloneness implies total isolation from and loss of all others, with emotions falling just short of feeling forsaken. Intense, painful aloneness is a feeling of inner emptiness accompanied by increasing panic. As an illustration of the relationship between aloneness and suicide impulses, it is worthy noting that in the last month of his life, Vincent van Gogh painted Crows Over a Wheat Field. And in one of his last letters about the painting, he wrote, "They are vast fields of wheat under troubled skies, and I did not need to go out of my way to express sadness and extreme loneliness." William Meisner observed about this statement that this comment reflects a terrible premonition of his suicide. Elsewhere, Meisner relates that Van Gogh had been labeled a lifelong outcast, stranger, and alienated person who was unable to secure human involvement and connection that would have contributed to making his life tolerable. This inability drove him into increasingly desperate isolation and loneliness that ended tragically in his suicide. In this context, we can see how sometimes the impulse to take one's life can be considered the only solution to end loneliness or escape an intolerably negative self-image. While maintaining relationships has been able to connect and help to address and protect against suicidality, some individuals will say, well, yes, my family loves me and I love them, but they would be better off without me. This rather ominous pronouncement conveys a deeper problem, as we can see in individuals like Van Gogh. When these individuals struggle with maintaining attachments, have conflicts or connections that are not maintained, they can feel more alone, thereby increasing their peril. For some, loneliness is defended against by not letting care in and becoming unable to make use of it. As a result, these individuals can become unreachable and may not respond to the soothing or comfort because they have not internalized enough positive experiences with others. Of course, there are religious components to that problem as well. This experience of aloneness may also repeat separation problems. However, it must be noted that some can make use of caring interventions. More recently, the tragic suicide of the famous psychoanalyst Bruno Bettelheim reveals that at the end of his life he said, quote, "In my past I had something very important to live for, but now, with age, particularly since the loss of my wife, here is this wish or idea of suicide," end quote. Later, his biographer, David Fisher, said, quote, "I regard Bettelheim's suicide as an attempt to end the torment, loneliness, and sense of futility about his present and future," end quote. According to Fisher, suicide was Bettelheim's way of, quote, refusing to fall helpless, his refusal to submit to a meaningless vegetative life, unquote. Current relationships, a spiritual life, and religion or other avenues did not appear to factor significantly in his decision to take his own life. A writer on the Holocaust and ambivalent about his Jewish status, there is much more to understand about Bettelheim's background. Regardless, in Bettelheim we see an effort to exercise both a narrowing, egocentric, and self-sufficient, as well as employing omnipotent defenses to ward off his suffering. In his own words, He conveys the control he tried to exert over his loneliness and the way old age factored so significantly in his suicide. Why do some individuals respond so negatively to emotions and experiences? One explanation comes from Melanie Klein. She proposes that the individual's task is to preserve the good object inside. In this sense, in order to preserve relationships, some people split off bad feelings and avoid loved ones. When excessive, these individuals become isolated because their genuine interaction is impaired and often blocked by not sharing deep concerns, especially conflicts with feelings that they fear will push away others. This can result in isolation and lead to suicide. Life is hard to sustain without relationships. Love is the source of life. Because love represents the good object in a psychoanalytic manner, it is only natural for people to sacrifice themselves for loved ones, according to Klein. On one hand, according to Klein, the good object is preserved. On the other hand, the good object is preserved by the inability to tolerate conflict and disappointment. When unable to repair and take in the good object while at the same time clinging to the bad object, this state of mind can also give rise to loneliness, which is in its extreme can lead to suicide. However, there are also those who are chronically suicidal, who are not living in this world effectively, nor able to leave it. During my internship, I saw an individual who had been in therapy off and on for many years, who had lethally attempted suicide by putting a gun into his mouth and pointing it up towards his brain. He pulled the trigger, and the bullet somehow traveled up through his mouth cavity, nose, frontal lobe, and finally exited his skull without taking his life. His face was disfigured by his action. He told me, "I can't even do that right." His twisted and sarcastic smile revealed years of bitter pain and disappointment. The child of 2 alcoholic parents and an alcoholic himself, he had no hope and was kept from suicide as best as, at least in his mind, by his fear that he would even mess that up. For him, disappointment and the humiliation that he seemed to fail at everything, added further to his pain. Let us now turn to some important factors in therapeutic treatment and crisis-oriented interventions for the suicidal individual. How might we respond to the urgency and the immediacy needed in dealing with the actively suicidal person sitting before us? Whether the suicidal person is a stranger, friend, family, fellow parishioner, or coworker, we all bear some responsibility once we learn of this condition, even if our role is only to help them find appropriate care. It can seem like it's all up to us in some moments. However, we must know our limits. Clergy should show concern and intervene as they can, but they should also have a clear understanding of their limits and their ability to help and access additional resources when needed, like a trusted healthcare professional, or in drastic situations, the safety of a 24-hour monitoring provided by a hospital. In my own practice, whether for an initial consultation or whether I have present or past concerns about the possibility of levels of depression or suicide, I begin with the broadest possible question: have you ever felt suicidal before? This allows for a full range of responses, including both historical and/or current preoccupations. Any history of suicide ideation or attempts is very important for predictive values to determine whether the attempt was very serious and to know how the attempt was resolved. To return to the authority of the research of Edward Schneidman, the suicidologist, on approaches to self-destructive behavior, Schneidman outlines a very effective and thorough strategy I will summarize here. The most critical functioning levels to assess are the patient's perturbation and lethality. Perturbation relates to the current and life circumstances that contribute to feeling suicidal. Lethality relates to the plans or intentions or the ability to carry them out. I once asked a patient about his intended method. He stated that he, quote, was going to starve himself, so I felt we had a bit of time. The primary goal is to reduce lethality by reducing perturbed feelings and to address the person's present concerns, assessing the involvement with loved ones, and addressing seemingly insurmountable tasks that can be changed in a practical way, thus problem solving. It is vital also to counter the suicidal person's constriction of thought by attempting to widen the angle of the mental blinders and to increase the number of options, certainly beyond the two options that have some magical resolution about being dead. Clearly exploiting that ambivalence, trying to pull that out and help expose the amount of ambivalence that they're experiencing, but they're not owning in their hyper-focus on their solution. The individual's mental pain also relates to the blocking of important psychological and spiritual needs. It is important to provide help in relation to those thwarted needs. In general, the goal of this crisis psychotherapy is to increase the patient's psychological comfort. In broader context, the crisis therapy should help the individual focus on feelings, especially distressful feelings such as guilt, shame, fear, anger, thwarted ambition, unrequited love, hopelessness, helplessness, and loneliness. Generally, the fear that focusing on these feelings will increase the person's despair and propensity towards suicide is unwarranted. This is penetrating the isolation. Very important. The feeling of connecting with you and your concern as well as having an outlet can go a long way. It is your monitoring. If your monitoring of their reaction tells you otherwise, then retreat from the strategy of penetrating the negative feelings. Further, according to Schneidman, a highly suicidal state is characterized by its transient quality, its pervasive ambivalence, and its dyadic nature. Ongoing monitoring until the crisis has subsided includes continuous monitoring, preferably daily, of lethality, consultation with professionals and other relevant peers. 3, consideration of hospitalization. 4, monitoring the transference or their reactions to you and how they're responding to your care and help. And involvement of significant others, and careful monitoring of the confidentiality, appreciating the laws and ethics that allow certain exceptions when necessary. All the while, the helper can find and exploit the client and patient's ambivalence. Another note of caution is whether a friend, family, clergy, professional, or other facility should be considered when the individual's needs exceed what the helper can provide. The helper need not, this is all of us, need not view the need for consultation or extra help as personal incompetence, but as an appreciation for the compassion and care provided along the way in the seriousness of the situation. More importantly, depending on the desperate nature of the situation, interventions such as collaboration that improve relationships may go a long way towards reducing the individual's disturbed state. An additional note is regarding suicidal fantasies. For many, these fantasies can be disturbing in content or to even know that one has these fantasies. However, they can be a surprising source of comfort or otherwise harmless, as mentioned before. Again, lethality must be assessed because suicidal fantasies precede deadly action. Clinically, suicidal fantasies that promote self-cohesion and relieve stress are vastly different than those that feed into narrowing of thought that may be oriented towards lethality or perhaps a plan of suicide. The differentiation of these two possibilities is useful not only in the present but also in the ongoing assessment and treatment. Okay, just a few brief words about spiritual considerations with suicide. We're going to ask Georgian to rescue us from these deep moments of despair in the mind to a spiritual perspective shortly. The Church relates many perspectives regarding suicide ideation. My focus is on the importance of psychologically penetrating the darkness so that connections and emotions may open avenues and perspectives to promote relationships with fellow human beings to God. Clearly, connection or communion is important for healing. The Church has known this for millennia. However, judgments, platitudes, or advice, and well-intended as they may be, may turn back many if they are simply labeled as sinful or fail in other ways to get at the suffering. When advice is insensitive or ill-timed, it may not be in touch with the spirit of God's love and grace. It also may do more to comfort the righteous than to bring back the lost. I think that it is important to understand that when we work with a suicidal person, to remember that Christians are called by faith and grace to suffer together with our fellow person and through the sufferings of Christ. I'd like to relate briefly what Father Thomas Hopko says about suicide. None of us have any right or competence to judge the eternal destiny of anyone under any circumstances, including the person who takes their own life. It is not, I want to say this is again a Christian teaching, as far as I understand Eastern Orthodox ancient Christianity, that people who commit suicide are necessarily condemned to hell. You cannot say that. You cannot say that about anybody, because we don't have the right to judge anything. God judges everyone. God knows why people do what they do. God alone reads the hearts of people. God alone will exercise mercy and judgment as he sees fit. And it is the Christian teaching that God has mercy on absolutely everybody. God does not withhold his mercy from anyone. That's the Christian gospel." Unquote. To add to the perplexity of not judging, in a story related by Father Hopko, is that after the suicide of a severely mentally ill 30-year-old woman who left a note saying, "Remember me, O Lord, when you come into your kingdom." With some of these ideas in mind, I'd like us now to turn to Georgian, who's going to talk about spiritual perspective.
Thank you, Stephen. Thank you for being here. Well, this presentation is part of an ongoing effort to bring my practice onto the foundations, the theanthropological foundation of our faith. And I am here because I want to share my experience and thoughts with like-minded people so that I can move this project further. However, initially I had no intention to present this conference this year, and Stephen's gracious invitation caught me in the process of returning to my home country after 20 years of being in the United States, and I was in conflict with my university for some ideological reasons that I'm not going to go into details. Anyway, I was at a place filled with grace at St. Anthony's Monastery in Arizona, and I was still struck by the suicide of a beloved medical student who applied to our program. And we were very upset, the faculty, that he didn't choose us because we thought, well, he would be such a good fit. We are teaching psychotherapy. So we met and thought, well, let's talk to him. Let's ask for feedback. Why didn't he come to us? And one of the colleagues called him. He agreed to come. And the very next day, we heard that night he killed himself. And imagine the grief at this absurd loss, and none of us was able to catch it. However, I was not new to this kind of unexpected suicide. In 2016, my process group leader at the Psychoanalytic Institute, a training analyst and former head of the institute, killed himself days after one of the most vulnerable, sensible, loving groups I've ever attended to, one that reaffirmed life and love. So deeply wounded and feeling betrayed and bearing the splinters of this deflagration in my soul, I pulled away from the psychoanalytic training. I should also add that a few days after I heard about this suicide, I had a session with a highly traumatized, dissociative patient of mine, actually a DID patient. And hours after the session, she overdosed. And then that's not the end. I mean, little did I know what was to come when I accepted the invitation. When she found out that I was going to leave, Suzanne, a long-term patient of mine and long suffering of a psychotic illness, stopped coming regularly and asked to be transferred. Tortured by Satan worshippers, these are her words, and enraged with her because she wouldn't be their whore because she loved Jesus, and would not allow her to die, but punish her with hospitalization and further torture for an attempt. Well, Suzanne killed herself after she promised she would come for a last appointment. I'm aware I put a lot on you. Right now I will move on, maybe return a bit to these cases. So what does it mean to look to such complex clinical cases through a spiritual lens? I've struggled trying to respond to this question. This is what I came up with. Regarding the whole life of a person, from the early childhood to the moment of the clinical encounter, and from that point on until death, within the frame of the economy of salvation, from an Orthodox Christian perspective. It means that I claim that I have such an Orthodox view, which is actually a tall claim. So it remains a question open to you. As Orthodox Christians, we talk about passions and sins and the mutilation of the resemblance of God in us, but also about metanoia, agape, and redemption. As therapists, we talk about trauma and its manifold manifestation, but also about the healing effect of the therapeutic relation. So, can we combine these two approaches? Or better, can the latter be absorbed into the former? We know that each sin is an act of self-mutilation, an act of mutilation of our natures. And there are levels of sins. And St. Nicodemus, the Hagioite, talks about 12. I'm quoting. From the beginning to the end, there are 12 levels of sin. The first is when someone does something good and does not do it well, but rather mixes good with evil. For instance, when someone offers alms, fasts, or performs other good things in order to gain recognition from his fellow men. The second level is stopping doing good altogether. And I'm skipping forward. The 10th, when the believer sins by force and oppression with or without consent. The 11th is disconcert and despair. The 12th, when man puts an end to his own life, his mind still healthy, yet defeated by despair. So if we look at this, we realize that we work with people that are the upper end of St. Nicodemus' chart, or even beyond it. Many of them highly traumatized. So we know that trauma triggers responses such as rage, disgust, shame, helplessness, and compensatory reactions that, inasmuch as the person loses command over himself, consciously or unconsciously, have a potential to further wound the self and the others. And trauma generates psychological black holes and death zones that presence, meaning, and speech can hardly penetrate. I believe that this path toward destructiveness can be slowed down and stopped by a life in faith. However, this process can also go very far. And what we see nowadays at the society level, I believe, is a long spiritual illness in the metastatic phase. And particularly upsetting to my conscience as a psychiatrist is the transgender epidemic that we have been facing and our response as a professional group to it. The channeling of human psychological suffering allegedly towards freedom, respect, and authenticity, but in reality, in a direction so obvious against the image and the resemblance of God in us, is obviously spiritual in nature. So it is no wonder that this brutal act of ontological self-mutilation generates such a high rate of suicidality. According to the review study of Meyer and McHugh, Sexuality and Gender, findings from the biological, psychological, and social sciences, I recommend it to everybody. published in the New Atlantis in 2016. The rate of suicide attempt along all ages of transgender individuals is estimated at 41% compared to under 5% in the overall US population. One study cited by the above authors found that compared to controls, sex-reassigned individuals were about 5 times more likely to attempt suicide and about 19 times more likely to die by suicide. I personally have not treated transgender people directly as a therapist, but I encountered a few of them as a psychiatrist. And I heard about them and their stories in trauma-loaded families when working with patients coming from such families. The complexity, I would say, of such clinical cases that look so far gone tells us that what we are facing is the result of a long process of accruing problems. And I have been thinking about how sin and trauma connect and transmit their consequences transgenerationally. And I hope that can be a topic for debate someday. So, how is it like to work with such people who are suicidal, acutely so? What enters in the room sooner or later and affects us? In Attention Interpretation, Winfried Bion describes a state of mind relevant to our discussion. Some patients I am familiar with achieve a state which I want to apply the term non-existence for a few moments at most. This is followed by an evacuation or externalization of non-existence. Non-existence immediately becomes an object that is immensely hostile and filled with murderous envy towards existence wherever it is to be found. And Bion does not refer to suicide or killing, but rather refers to psychological death. So unleashed in the therapeutic space, such a wave of non-existence cannot but hit the therapist hard and deep. So the encounter is forcing us onto a path towards the heart of darkness. And actually, I have returned from the valley of the death, we later found out was the opening statement of our candidate, who later killed himself. So what do we have to offer as Orthodox Christians and therapists? First, in psychotherapy, the therapist is supposed to help the patient bear the pain, teach him to mourn and suffer, as Stephen was teaching us, and be grateful, be compassionate, and have hope. So models such as Winnicott's holding environment, Bion's container-contain, Kohut's transmuting internalization, Bromberg's being in spaces, the shadow of the tsunami and the birth and the growth of the relational mind, all reflect the necessity of deep presence, of the deep presence of the other in order for healing to occur. What we have to offer, I say, I'm probably much more than I'm going to say. I'm going to, though, mention 3 premises here. In Christianity, the internal world of man is not directly open to him, but only disclosed to him in relationship with God. We get close to each other in a deep way only when we get close to God, when we fulfill our ontological destiny in Christ. And I think that should be reflected in the way we approach our training. Second, there is no dead end from a scriptural perspective. Everything is possible in Christ. All perceptions of dead ends are the devil's work. Think about Job. However, from the perspective of secular psychology, we never know. We have to learn how to live with uncertainty. Actually, worse sometimes. I have encountered that with many psychoanalysts that insist that we have to live with a negative certainty, that we all die and that's it. But the example of Salman Akhtar comes now to mind. I attended a conference about death instinct, and psychological death. And he opened his speech by telling us that he came to tell the truth. A man's life starts from the moment he's born in the mind of his ancestors and dies with the last of his successors that remembers him. Well, what do we know? We know that we are supposed to go, after we die, to go and see him how he is. Premise 3. When God shows us our sins so that we see them, he also offers his mercy. When the enemy incriminates us for our sins, he wants to hide from us both God's merciful love and our own goodness as image and resemblance of God. I have an example here. I met a man in my church, a convert, an Orthodox convert. And he said, I was the 7th in the line of 7 suicidal fathers. I found my father hanging. He found his father hanging. That was up to the 7th generation. And I met this priest monk, an Orthodox priest monk. Whatever that man did with me just made me another person. And he was on a different path, now in the church, with all that load, but very different man. And this is not an ordinary therapeutic encounter. This is an encounter in Christ. So, I'm going to end with what will be some principles of treatment, a psychotherapeutic treatment that is also Orthodox Christian, I would say. And first, I'm going to advise you what I myself haven't done, that is to dissuade people who want to pursue this career and you see that they are not prepared. We were not able to catch this medical student. He probably shouldn't have picked psychiatry, even though he was very talented, apparently, at it. Also, in times of turmoil and trouble in your own lives, maybe we should all stop seeing patients for a while, or at least not see those patients whose problems are too similar to ours. Second, the preparation of therapists. The ascetical path, the good fight against the passion, that which is a life in Christ, should be front and center for all of us who are in this profession. Don't need to be a confessor priest to have such life. And I recommend a famous paper, the Buin-Malzberger paper, Counter-Transference Hate with Suicidal Patients. And where you can read about a whole range of toxic counter-transference response. That's cruelty, vengefulness, aversion, hatred, of course. Now, can you imagine a man cleans from passion having such responses? I don't. I don't see Saint Silouan responding like this, or Elder Sophrony responding like this. But we probably don't need to be like them in order to be able not to respond like this. Now, therapists come to know themselves with their own therapy through psychoanalysis, and I've done that myself. I'm not going to say that this is not good, or it doesn't have obvious merits. But there is still an extended engagement with the darkness in us. And if it happens in the absence of God's light, I think that we can get trapped there. Laying on that couch, aren't you at risk to spend too much time in bed with the enemy? And we can argue with the case of Bettelheim or the case of the psychoanalyst I was talking about. Then we can think about St. Porphyrius, who said, nobody became a saint by fighting the evil within. People became saints by falling in love with Christ. So don't go and fight with that evil first. That's his path. 3, therapy beyond therapy hours. Cheerful prayers for the patient. According to Saint Silouan's model, who was an intendant on a monastery in Mount Athos. And he was the most successful of the intendants there, even though he was the one who was least supervising his workers. So the others came and said, "Father, teach us what you're doing. We all care about the monastery and its wellness." He said, "Well, I go in the morning at the workshop, I tell them what they have to do, and then I retreat to my cell and pray for them with tears. Look, God, poor Nikita, how difficult must life have been for him in that village of his, that he left his family, his wife, his parents, to come here to work. For what? For nothing. Please have mercy on him." And then the next, and then the next of his workers. So, you know the saying, a monk that prays only when he is praying is a monk that does not pray at all. We may perhaps say, if a Christian therapist is therapist only during the therapist hour, he is not a therapist at all. Let's think about that. 4. Suffering with the patient in the time of darkness with the faith and hope in God's mercy. I'm going to give you a quote. "When we find ourselves in the time of darkness, let us not be troubled, especially if its cause is not within us. Attribute this to God's care for reasons that He alone knows. There are times when our soul feels like choking and sinking in the waves. When one either reads from the scriptures or serves the liturgy or seeks to know a certain thing, darkness after darkness comes over him, and he often quits his job and wants nothing to do with it, and believes that no change for better will ever happen to him, and peace will never return. In this hour, he is filled with despair and fear, and the hope for God's help and the consolation of faith have completely left his soul. He is fully filled with fear and doubt. But those who were tempted by the surge of this hour know, from their own experience, the change that occurs at the end. God does not abandon the soul in this state for a full day, for then the hope of Christians will be lost. Rather, He quickly puts an end to this state." This is from St. Isaac the Syrian, Ascetic Homilies 57. You'll not find this in English. This is a translation from the Romanian edition of Father Dumitru Stăniloae. And here is a prayer, too. "O Virgin, heal me. I am sick and in a place of malice. Transform my illness into wholeness." From the Paraclesis of the Mother of our God. And finally, number 5. Experience the cross with Christ and the patient. The darkest hour. The therapist feels that he cannot prevent death and is doomed with the patient. He feels the shame, the helplessness, and the sadness of the situation. Like Christ, therapist feels forsaken, as if bearing the full burden of death without an exit. My God, why have you forsaken me?" Yet Christ does not end his work in the forsaken place. By delivering himself to God, he ends in communion with the Father. "Father, into your hands I commit my spirit." So shall we. So, therefore, our model is a paradoxical one. Theodoret of Cyrus, a 5th century theologian, says, "Behold, an extraordinary and strange way of healing. The doctor submits himself to the operation, and the patient is cured." Thank you. We have some time, very little time, for some questions at that microphone.
Go to the mic for the questions.
I realize this conference is not on the complex gender issues. I would like to point out, though, that one way of interpreting the increase in suicide rates of those of gender minority is as a function of alienation. And it's possible to see the perspective that you voiced as being part of a perpetuating cycle of that alienation. So just something to keep in mind.
I would just like to say that I was appreciative to hear you, Georgie, make the observation, and you did it in several ways, that therapeutic endeavor that we're striving for has an ontological dimension in which all of this takes place in and through Christ, and that the training, if I heard you, of therapists must include this. This is enormously important. I rarely hear this mentioned, and it has huge implications for the entire field because it is an invitation for a lifelong journey of repentance and of self-transparency before God and one another. And I thank you for that, and I heard a lot of bells ringing.
Thank you.
May I add something I want to respond to with that is we live in a world with this twisted belief that you can do anything you want to, and this isn't really true. We need to sometimes dispel those ideas.
Thank you. Yes. Can you? For our ancient faith.
I want to thank you also for speaking about this descending into the darkness with the patient. Being there, it is always shaking the earth of the soul to be there. It's very real, and it's very difficult. It is easy to step back. It's very scary, even for a minute. We know that Christ doesn't leave us in the tomb, not for 3 days, not even for one, but we don't remember at that moment. I worked in the field of palliative care for many years, and being with people nearing death, it was difficult to be with the wish for death, just to stay in control, just to go around the terrifying loss that's anticipated. So I was acutely aware of how difficult it is to go down, in a sense. So I am very grateful for what you said, and also echoing Stephen for just articulating more openly the spiritual dimension of our work. It's intimidating a little bit because I think there's been an Orthodox hesitation for years and years and years, and now we're kind of moving a little into doing this more openly, but there's been a hesitation to even touch upon the spiritual implications. It was sort of viewed that thinking in terms of the spiritual situation of a person we're helping is a clergy's domain, and that we should stay in our little box. But of course we know that's impossible, and it does affect us. So whatever that can be done to develop more this kind of thinking is very helpful to all of us. Thank you very, very much.
Thank you, Joanna, for sharing this. Time for...
I think there are a few of us who have been trained theologically and are now, and have been trained clinically, either both and or, but we're left to our own devices often to integrate the two. And I do want to hear from either or both of you, how do you go home with that heaviness? Like what do you do with it?
The heaviness of having such a difficult encounter with patients, that's what you mean?
Yeah, a difficult session. Yeah.
Right. Well, I don't have a recipe for that. I know that talking, confessing, praying, I don't have a guide either, other than my spiritual father and the life of church. And Good Samaritans, people who want to talk. But I'm trying to figure out if we can do more about that. Yes.
I think in one sense you answered part of your own question by saying that you have the clinical and the theological training and then are left to your own devices. We really need care, supervision, consultation at a deep level of the person, of the therapist, for a number of years. So many programs now are just teaching the head. The person-to-person encounter is vital, and Orthodox, in one sense, understand this better in some ways than any of the traditions. So take your own advice and go find yourself someone who can help you with that, because we don't do well alone.
Yeah, I'd like to echo that as well. I think in addition to being able to debrief or talk through things with someone and not just go it alone, to be affected by suffering and suffer with someone, you don't just suddenly become immune from it or something. Now you're the super mental health professional walking out of the office. Sometimes it's the rest of the night is sort of a period of suffering and letting it wash over me and in prayer and waking up the next day, a new day. But sometimes the wave of suffering just also is something to go through.
Both will be ready for Vespers in about 5 minutes, so take a break. Thank you.
Okay.